You want to take it again? You could.
Candy?
Where'd this come from?
Really cold.
I need it. So. Well, I don't need it.
I'm gonna put some Diet Coke.
Can we not talk about it?
It's better when it's out of the OCU bottle.
I'm surprised I did.
Yes, it is.
Well, when I did mine.
I did. There's a lot
It makes me feel
of things
smart.
I didn't know.
I hope this doesn't have future bad. Making it have it.
No, I hope not.
Second level here. So the lungs, when the lungs developed, they started out with a tracheal bud that grew down from the oropharynx into your chest, and then it bifurcated. The chest cavity was lined with a membrane. We have two chest, you have right and left chest cavity. These lung buds, as they grew into the chest cavity, they pushed the membrane that was on the medial side out there with them. So you actually, if you think of the chest cavity with that membrane as a balloon, and this is your lung bud growing down, it grows into the balloon. So you have part of the balloon that's on your fist that is continuous with the outside of the balloon. That forms a visceral pleura and a parietal pleura that adheres to the chest wall. And between the two is the pleural cavity. The pleural cavity contains a couple of cc's of fluid to help with lubrication as the lung moves in there, expanding and contracting. Or it doesn't contract, it's expanding and relaxation, I should say. There's also an area where, if you notice, the lung does not expand into the whole chest cavity. There are places where there's parietal pleura adjacent to parietal pleura without any intervening visceral pleura or lung tissue between them. I'll explain that more here in just a minute. You name the parietal pleura by its surface, whether it's against the diaphragm or against the ribs or in the middle against the mediastinum here. And then around where the lung bud grew in is called the root of the lung. It's also called the hilum. Hilum is the entry point of viscera. You have a hilum of the kidney, a hilum of the spleen, a hilum of the lung. Now, one thing that I'll show you later on, but it's easy to explain it here. You see how the lung bud is growing in at an angle? And that's what it does. It grows in at an angle. It doesn't grow straight in. If it grew straight in, then you would have the visceral pleura just around the lung and then becomes continuous with the parietal pleura, right? It'd be nice and no folds, no pleats or anything like that if you went straight in. But it comes down at an angle, and when it comes down at an angle, it creates a fold down here below it. There's a fold of reflection where visceral becomes parietal pleura. That fold is called the pulmonary ligament. And it's because this thing grows in at an angle. You'll see it in a subsequent slide, but it doesn't make any sense unless you think about how this thing is growing in that balloon. If you push your hand into a balloon, it's going to form a pleat down here. That's the pulmonary ligament. Now, in places where the lung tissue with its visceral pleural on the outside, doesn't get between two layers of parietal pleura. This is called a recess. Two recesses that are most prominent are in the back here. They're called the Custo diaphragmatic recesses. Custo diaphragmatic recesses. Your lung cavity goes all the way down to T12. But the lung itself only goes down to T10. So there's a couple of joints, a couple of spaces there, vertebral spaces, where there is no lung. It's just empty space. You can view it better from the side, where you have the diaphragm, the dome of the diaphragm like that, and then the lung tissue is like that. That's the Custo diaphragmatic recess. Another thing you have to keep in mind about this situation is that, remember that the ribs go out and then down like that. Well, so does the first one. It comes out and then down. In fact, the parietal pleura is actually, so the parietal pleura would be up to the rib at the back. So it's up to here. But in the front, it's up to here, but my first rib was down here. So you actually have parietal pleura extending above the anterior rib. The parietal pleura actually extends above the anterior rib. So when you take a stab wound or a gunshot wound right here, you're going to wind up interrupting that parietal pleura. Now the other thing about that pleural cavity, I said there was a little bit of fluid in there. Parietal pleural cells withdraw oxygen from the pleural cavity, creating a negative pressure inside the pleural cavity. So the air is sucked out of the pleural cavity, essentially, if you want to put it in another term, by the parietal pleura, creating a negative pressure. The lung itself is just a ball of elastic tissue. If you release the negative pressure, where you equilibrate it, you poke a hole in the parietal pleura and let the outside air go in, then the lung, being elastic, will just collapse on itself. It's the negative pressure that keeps the lung inflated. It's the negative pressure of the pleural cavity that keeps the lung inflated. There are two more recesses, just for the completeness I want to mention. You'll never really see them. In front of the heart, here's the heart. There are two places right here called costo-mediastinal recesses. It's just where the parietal pleura wraps around the front of the heart. It's not really clinically relevant, but for completeness, I just wanted to show you where it was. The ones that are most clinically relevant are the Custo diaphragmatic recesses out here. And you can see these recesses right there. The dome of the diaphragm, you actually have, you don't have one diaphragm, you have a hemidiaphragm. There's a right and a left hemidiaphragm. You can see the dome of the hemidiaphragm comes down to a sharp point. There's one point, there's the other point. If you look at the diaphragms here, you've got the heart sitting on the left, you've got the liver pushing the right up, so the right hemidiaphragm should be higher than the left. If you come over here and look at this lateral view, here's the right hemidiaphragm here. Goes all the way from the back to the front. Here's the left hemidiaphragm watch this. Here it comes up right here, and it stops. Where did it go? The muscle of the diaphragm is the same density as the muscle of the heart. So you can't distinguish them. So this is the heart sitting right here. The diaphragm does indeed continue forward. You just lose it in the same density as the heart muscle. So if you look at a lateral chest x-ray and some physician, your preceptor saying, which one's the left and which one's the right hemidiaphragm, you say, oh, that's the left hemidiaphragm right there. That's the right hemidiaphragm up there. And you'll be like a rock star. Now if you're standing up, where's fluid going to go?
Down.
It's going to go in these angles, which is what happens here. You can see, oh, by the way, a chest x-ray, when you look at it, is like the patient is looking at you. So this is the patient's right. If you look at the left, the angle here is sharp. The Custo diaphragmatic angle is sharp. Over here, it's blunted. There's fluid on the right. If you look at this illustration, you can see that there's a sharp angle right there, but there's so much fluid on the left, you actually have a meniscus of fluid. Now if you look at that chest x-ray, this one on your right, and you say, well, wait a minute, is that fluid within the lung or fluid outside the lung? Is it within the lung or outside the lung? Because it's going to look the same. The easy way to tell here is to turn the patient on their side. If it's outside the lung, it'll pool at the bottom. This position is called a lateral decubitus position. If you're wondering if that is that a lung, is that a fluid volume? Just turn them on their side. You can also get a CT. In this example of the CT on this side over here, you can see the lung tissue and the fluid accumulated outside of it. Over here, the fluid is within the lung tissue. So that is a pulmonary effusion. This is an infiltrate. I said pulmonary effusion, pleural effusion. Pleural effusion versus infiltrate.
Is it pleural infiltrate or pulmonary?
Pulmonary infiltrate, because it's of the lung, not the pleural. Now, I said if you poke a hole in the parietal pleura, the lung will collapse. That's called a pneumothorax. And that's what's happened here. There's the entirety of the lung right there. If you look over here on this side, you see all these little strings? Those strings are blood vessels running through the lung tissue. You should be able to follow the strings out to about 1 centimeter from the lateral chest wall. And that's a fully expanded lung. This is the vasculature of the lung. Not the airways, you can't see the airways. These are the blood vessels of the lungs. Over here, you see nothing but black. So this is a pneumothorax. You can get a pneumothorax by poking a hole in the parietal pleura, right? You can also get a pneumothorax by poking a hole in the visceral pleura. You understand how that would happen? The visceral pleura, if I poke a hole there, what does that communicate with? Your mouth. People who are tall, thin, mostly high school basketball players, that all the time, at least once or twice a year, you'll read about it in the paper or they'll show up in your clinic. They come in complaining of shortness of breath. Well, these tall, thin, they create blebs on their lungs. They're like little vesicles of the lungs. And when they rupture, they produce a spontaneous pneumothorax. But that's of the visceral pleura. As opposed to the drug deal gone bad, and you took a 9 right here, and it went through your parietal pleura, and will probably go on through your visceral pleura and out the back too. So what you have in a simple pneumothorax, or spontaneous pneumothorax, is you're going to have decreased breath sounds on that side, the evolved side. Respiratory distress, anybody that drops a lung is going to be having air hunger. Now, in these high school basketball players, if they just drop the lung to maybe 10% of the volume, you don't need to do anything with it. Just send them home. They'll heal up the little hole, they'll be just fine. But if it's bigger than that, then usually you have to do something else to it. You would definitely have to do something to this, like put a chest tube in that I'll show you in a second. A mediastinal shift to the pneumo side. This is the mediastinum. The mediastinum is all the stuff in the middle between the two lungs. Because you've got all this new space, this mediastinum will often shift to that side. And the trachea, if you look at the trachea, if I have a simple pneumo on the right, the trachea will actually deviate to the right. And because you have all this new space here, the dome of the diaphragm will be exaggerated. Because it'll move up into that new space, right? So these are the signs and symptoms of a simple pneumothorax. There's another type of pneumothorax, it's called a tension pneumothorax. A tension pneumothorax occurs usually as a result of blunt force trauma to the chest, like a roofer falls off a roof, or a car wreck where you get impaled, you hit the steering column, or something like that. Blunt force trauma to the chest. What happens with that is you have a tear in the visceral pleura. Creates a flap. So every time you breathe in, air escapes through the flap into the pleural space. When you breathe out, the flap closes, trapping that air. So with every breath, you trap more air in the pleural space. And this thing builds very rapidly over time, and it's under tension. Now, because you're going to learn the superior vena cava runs right here, this thing can impinge on the superior vena cava. If you have no blood return to the heart, you're going to have no blood leaving the heart. So in a tension pneumothorax, you'll have a falling blood pressure and a rapid pulse. Falling blood pressure with increased pulse. Now you're also going to have decreased breath sounds over the affected side. But because it's under pressure, it's going to push the mediastinum to the other side. Push the mediastinum away from the decreased breath sounds. A simple pneumothorax, it goes towards the decreased breath sounds. Tension goes away. The trachea will deviate away from the affected side. And because it's under pressure, it will push the dome of the diaphragm down. It will flatten the diaphragm, the hemidiaphragm. If you have no blood flow returning to the heart and no blood flow leaving, but the heart is sitting there contracting, or at least the electrical output of the heart is clicking along just like nothing else was going on, So the electricity of the heart looks fine, but there's no cardiac output. That's called pulseless electrical activity, PEA. If you look at the EKG, it looks fine. Or the rhythm, the monitor that's on the screen, it looks fine, but there's no pulse. There's no pulse because there's no cardiac output. There's no cardiac output because there's no end-diastolic filling. There's no end-diastolic filling because the superior vena cava is compressed. And if you don't fix it, you are DED, dead. And the way to fix it is to just, I know there's an A in there, but for emphasis is DED, dead. You do not send these people down to the scanner to get an x-ray. If you get somebody coming in, having been in a car wreck, they've got a pulse of 120, they've got Paul's got a blood pressure of 72/40. He's in respiratory distress. Then what you're going to do is you're going to identify that second intercostal space on the affected side, and you're going to stick a 14-gauge needle into his chest without a chest x-ray. You better not be wrong. Okay? If you send him to the for an x-ray, he'll be dead by the time he comes back. You're decompressing the tension. And you should see an immediate rise or return of blood pressure. Okay? If you stick a needle in somebody, it's called darting the chest.
Darting.
Like throwing darts at them, darting the chest. What you actually do is you take a 14-gauge needle and you stick it through if you got a glove right there, you stick it through the glove so that the glove is hanging off of the needle, the hub of the needle, and you just hold it like that and stick it into the chest. Because the glove itself will act as a valve. The pressure will come out, but when it tries to suck back in, the glove will prevent air from going back in. They have commercial valves, but if you're at a loss for it and you're in a hurry, just stick the needle through the glove and dart the chest. Now, once you do that, you're going to have to put a chest tube in them now. And what a chest tube is, and you'll do this in December, in on each other. So you'll learn how to put a chest tube in. Where is the chest tube going to go? Over a rib, not under a rib, over a rib. Huh? Yeah, you're going to put the tube in over top of a rib. Okay, so here you can see that the radiopaque markers on the tube, and it's going into the cavity, chest cavity. Then you take the tube and you hook it up to a thing called a Pleura here, which is a water trap, and then that's hooked up to the suction on the wall back there, and it reestablishes the negative pressure inside the chest cavity. It also allows for things to drain if you're bleeding in your chest cavity from that gunshot wound. So anytime you have a collapsed lung, you're going to put a chest tube, which is a brutal procedure. This is the needle decompression I was just talking about. Identify the second intercostal space. That right there, you can see that there's the pneumothorax. Look where the heart is. It's shifted all the way over to the left. That's a tension pneumo right there in that little kid. So you're going to have to identify that second intercostal space, stick it in on the right side, right there. Well, let's see. There's one, first rib, second rib, and go right there. The respiratory tree is starts with the trachea, right below the cricoid cartilage. you have tracheal rings that actually are not rings, but they're C-shaped pieces of cartilage. It goes all the way down to the carina. The carina is the place where it bifurcates right here. It's located at the angle of Louis. So if you take a gunshot below the angle of Louis, you will not hit the trachea. This particular cartilage is called the carina. It looks like a pair of tighty-whitey underwear.
What?
The carina.
Oh, oh, got it.
It looks like tighty-whitey underwear. So the trachea bifurcates into the right and left main stem bronchi. You can always also call them primary bronchi or main bronchi. I don't care what you call them. Well, you have to call them something reasonable. The right main bronchus has a greater diameter, it's shorter, and it's more in line with the trachea. The main bronchi divide into secondary bronchi or lobar bronchi. As it says right here, in terms of lobar bronchi, there are 3 on the right, 2 on the left. So you have 3 lobes in the right lung, 2 on the left. The lobar bronchi divide into tertiary bronchi that'll go to supply bronchopulmonary segments. Provide the air to bronchopulmonary segments. As I'll show you in the next slide, you have 10 bronchopulmonary segments in each lung, supplied by a tertiary bronchus and a branch of the pulmonary artery. That defines a bronchopulmonary segment. You do not need, each of these segments has a name. You do not need to know that. You do not need to know the name. You need to know what a bronchopulmonary segment is. But when you send somebody for a bronchoscopy because of a suspicious lesion, they will go in there. Each of these tertiary bronchi has a name because it's going to a specific bronchopulmonary segment. They will show you this illustration, and then they'll put the lesion on here, or where they biopsy, or whatever. So if you're doing bronchoscopy, you work for a pulmonologist, you're trying to interpret the results you got back from the pulmonologist, you will need to know this. But for our sake here, we just need to know primary, lobar, or secondary, and tertiary, or bronchopulmonary segments. Now, the lobar and tertiary, you lose the ring shape or the C-shaped structure. They're plates of cartilage. It's only in the trachea and the primary or main bronchi that you have the C-shaped rings. And I put this in here not because of any clinical relevance, really. Actually, it does have clinical relevance when you're trying to interpret a chest x-ray. So you probably should know this. All of the lobar bronchi are inferior to the pulmonary arteries. Got right and left pulmonary arteries right here. All of them are lower than inferior, except one. The one going to the right upper lobe is above the right pulmonary artery. That's called the eparterial bronchus. Ep meaning above. Eparterial bronchus, right there. That's going to the right upper lobe. And the reason I say that it's relevant on a chest x-ray is when you're looking at a lateral chest x-ray, like that, and you can see right here in the hilum of the lung the different vascular structures and pulmonary structures. So the bronchus, the arterial bronchus, is going to be a hollow circle above it all. So in terms of localizing lesions in the hilum, this is relevant. Features of the lungs, 3 lobes on the right, 2 on the left. Both lungs have an oblique fissure. The right lung has a horizontal fissure. The left lung has a cutout here for the heart. It's called the cardiac notch. And that makes that little thing right there of the upper lobe look like a tongue. That's why it's called the lingula. Where's the lingula? It's in the left upper lobe of the lung. Lingula. This also, up here at the top, is called the cupula, which is the part of the pleura that extends above the first rib is called the cupula, C-U-P-O-L-A. Cupula. I failed to mention that earlier. So where you want to make your cut today is you just want to cut right here. Pull the thing out. Now, there may be some adhesions. Remember we talked about inflammation and the types of adhesions, fibrous adhesions. Some of you will probably encounter that today. When you look at the lungs, this is what you're going to see. If you make your cut absolutely perfect, you'll have a slice through the main bronchus. You'll have 1 pulmonary artery going into the lungs, and you have 2 pulmonary veins coming back out. But you will not make a perfect slice. Nobody ever does. Things will either have already split, you'll have the lobar bronchi, or you'll have the veins that haven't coalesced into the 2 pulmonary veins. You'll have like 6. What the hell? So don't get too excited about it. Feel them. Feel them. You can identify the airway because you can feel the cartilage in the wall. If you look at the different sections through the vessels, the thick-walled vessels are the pulmonary arteries. The thin-walled vessels are the pulmonary veins because they've already been through the capillary bed of the lungs. They're low pressure. Note that the pulmonary artery is carrying deoxygenated blood. So it can't supply the lung tissue itself with oxygenated blood. Those vessels come off of the aorta, and you see them right here between these great vessels. They're called the bronchiolar arteries and veins. If you look real hard, you may find them. They'll be about 1 millimeter across max. They're very tiny, which tells you there's very little tissue that they're going to supply. The lung tissue is mostly just air space. Now, because they're perfused, they're full of fluid, so they're all inflated. But when they're deflated, as you saw in that pneumothorax, there's not much to it. And finally, this is the pulmonary ligament right here that I mentioned earlier. This is the reflection of the visceral pleura onto parietal pleura. You have a right and left, you have a pulmonary ligament on each side. You know, depending on where lung lesions are, they can go in and remove a lobe because they have their own separate vascular supply. They can even go in and remove a particular bronchopulmonary segment if they have to. The lymphatics of the lungs are towards the hilum. Lymph flow towards the hilum. And you're going to be dealing with lymph from the lungs on every chest x-ray you take. And there are going to be hundreds of them your clinical year. Okay, so here we go. Here's some lung cancer. What does lung cancer look like? Well, that little thing right there, it's called a coin lesion. Looks like a coin. That's pathognomonic for lung cancer. On this CT up here, you can see a lesion right there. Very prominent lesion. This is the normal lung over here, it looks like. A female, you can see the breast right there. And this one right here, you got it's a breast. It's a wide, with all the ribs intact. It's a wide mediastinum from invasion of the lymph nodes of the cancer cells. You see how wide that mediastinum is versus that one up there? That's never good. This big old thing right there is not good. So you would take this person and send them immediately for a CT. The autonomics of the lungs, we've already been over, so you already really know this. The parasympathetics are by the vagus nerves. The vagus nerves come down as a right and left vagal trunk, or right and left vagal nerves. They enter the chest. You can find them today. And then they dive into this cardiopulmonary ganglionated plexus. Cardiopulmonary ganglionated plexus. That's where they're going to find their postganglionic. And then it's just going to hop off from there right over to the lungs or to the heart. So that's the parasympathetics. The sympathetics, we've seen this 100 times. Preganglionics enter the chain, they synapse and come out as cardiac nerves and go directly to the heart. They don't use the cardiopulmonary ganglionated plexus. They've already synapsed. If you put the two together, it looks something like this. The blue, well, the green represents the vagus. They're going to synapse in here and just go right to the lungs. This color over here would be the sympathetics coming out of the chain as postganglionics, as you see right here, postganglionics. Going straight to the viscera. So what is the impact of the autonomic nervous system on the airway? We know fight or flight. Sympathetics are going to dilate the airways as you're running. So parasympathetics are going to decrease the diameter of the airways. Parasympathetics also increase glandular secretions. The sympathetics do the exact opposite. You know, when you're out jogging, you're running, and you don't have much in the way of secretions in here, right? From saliva or tracheal secretions, you're dry. So how you would use this to your advantage is, if you have an asthmatic, you want to open the airways. So what I want to do is I want to give you something that mimics the sympathetics. That's called a sympathomimetic. And they're short and long-acting sympathomimetics. Albuterol, or one of the trade names is Provenal, or Ventolin is another one. That's all it is. It's a beta agonist. It stimulates the sympathetics. that dilate your bronchioles. But that's only half the problem in asthma. In asthma, the other problem is mucus plugging, the amount of mucus that you secrete. You want to dry them up. So what I'm going to do is block the parasympathetics. If the parasympathetic increase glandular secretions, if I block them, I'll decrease glandular secretions. That's called a parasympatholytic. Ipratropium or Atrovent is the drug you're going to use every day. So when somebody comes in with an asthma exacerbation, they're wheezing, they can't breathe over to the clinic, or you give them a nebulizer containing 5 milligrams of albuterol and 1 milligram of Atrovent. That'll dilate them and dry them up. Now what you don't want to do to an asthmatic, oh, go ahead.
How do they not like cancel each other out? So when's
Because they're working on different limbs of the autonomics. This one's working on the sympathetics, it's stimulating the sympathetic. This is blocking the parasympathetics. What you don't want to do to an asthmatic, then, is give them something that will block sympathetics. Right? You don't want to block their sympathetics. That's why you don't put asthmatics on beta blockers for high blood pressure. Beta adrenergic blockers. It's as simple as that. And that's all we got to say about that. See, this is the fun part. This week, this will be a fun week, because this is, the big stuff, and it's like, oh, wow, that's what the heart looks like. So, this will be good stuff, okay? Let's go on over there.